Welcome to the deep dive. Right, today we're tackling genital warts, condylomata acuminata, essential stuff for your MSRA.
Definitely.
We've got the revision notes here, definition, causes, risks, the lot. Our mission, pull out the key info you actually need to remember, make it stick without, drowning in detail.
Sounds like a plan. Let's get straight into it.
Perfect. So kicking off, what exactly are genital warts? The basics.
Okay, so genital warts are a really common STI, a sexually transmitted infection. They're caused by certain types of the human papillomavirus, or HPV.
Right, HPV. And what do they look like typically?
You're usually looking for small bumps or growths. They can be flesh-colored, maybe a bit grayish sometimes, and they appear on the genitals or around the anus. Importantly, they're benign growths, so not cancer, often called anogenital warts.
Benign, okay.
Yeah.
And you mentioned HPV types. Is it specific ones we should link to warts?
Yes, exactly. For genital warts, the main culprits, the ones you really need to remember, are HPV types 6 and 11.
6 and 11, got it. Because you hear about other HPV types, 16 and 18, linked to cancer, right?
Absolutely. Types 16 and 18 are the high-risk ones for things like cervical cancer. But for these warts we're talking about today, it's overwhelmingly 6 and 11. They're considered low risk for cancer.
Okay, clear distinction. So 6 and 11 cause the warts. How does someone actually get infected? What's the etiology here?
Well, the main way it spreads is through direct skin-to-skin contact, specifically during sexual activity, so vaginal, anal, even oral sex. It's that very direct contact with an infected area.
Direct contact. Makes sense. Any other, maybe less common ways it can be transmitted?
Yeah, there are a few, though they're less frequent. There's a small possibility of prenatal transmission, so from mom to baby during birth. Also, something called auto-inoculation can happen.
Auto-inoculation?
Yeah, where someone accidentally spreads the virus to another part of their own body. And very rarely, heteroinoculation, spreading it to someone else through non-sexual contact, maybe sharing towels, though that's debated and less common.
Interesting. And how easily does it pass between partners?
It's actually quite transmissible. The estimated rate between sexual partners is around 60%.
Wow, 60%. That's high.
It is. It really shows how easily HPV, especially these type 6 and 11 causing warts, can spread through sexual contact.
Okay. So given how common it is, who's particularly at risk? What are those key risk factors we need to flag for the MSRA?
Right, risk factors. Several things stand out. Unprotected sex is a major one, obviously. Having multiple sexual partners also increases risk, as does starting sexual activity at a younger age.
That makes sense. Anything else?
Yeah, a history of having other STIs is a risk factor. Smoking, interestingly, is linked to.
Smoking, really?
Yes. And also, anoreceptive intercourse anal sex is a significant risk factor. And finally, being immunosuppressed, so having a weakened immune system, maybe due to HIV or certain medications, makes you more susceptible. Basically, more exposure or a weaker defense.
I guess if someone comes in with warts, we should think about other STIs too.
Absolutely, that's a crucial point. Studies suggest up to 20% of people with anogenital warts might have another STI concurrently. So yeah, screening is often recommended.
Good reminder.
And just to link back, while HPV 6 and 11 are low cancer risk, the concern is someone might also be co-infected with high-risk types like 16 or 18. Oh, and one more thing, perianal warts, the ones around the anus, can sometimes show up even if someone hasn't had anal sex, maybe spread through fingers during other sexual practices.
Right, okay. Lots to consider there. So let's go deeper. What's actually happening on a cellular level, the pathophysiology?
Okay, so HPV, the virus, it targets the skin cells or the cells in the mucous membranes in the genital area. It gets inside these cells and basically hijacks them to replicate, to make more copies of the virus.
And that replication is what causes the wart.
Exactly. That viral activity leads to the overgrowth of cells, forming those benign warts that you can see. But a really important aspect is latency and persistence.
Latency, meaning it can hide.
Sort of, yeah. The virus can become latent. It's still there in the cells, but it's inactive, not causing visible warts. Or it can persist at a very low level. This is why warts can sometimes come back, recur, even after treatment seems successful. The virus wasn't completely eliminated.
Ah, okay, that explains the recurrences. Now, practically speaking, you see a lesion. How do you know it is a genital wart and not something else? What are the key differentials?
Very important question for exams and practice. You need a mental checklist. I like the mnemonic MSEHSPVCIMC. Bit of a mouthful, but it covers the main ones.
Okay, let's break that down. MSEHSPVCIMC.
Right. Molluscum contagiosum, those little pearly bumps, often with a central dip. S, skin tags, just fleshy bits of skin.
Mm-hmm.
E, epidermoids, small lumps under the skin.
Okay.
H, hair follicles, and S, sebaceous glands, normal structures that can sometimes look prominent.
Right.
P, pearly penile papules, and V, vulval papillomatosis. These are crucial because they're normal anatomical variants. Need to reassure patients about these.
Right, normal variants. Good point. Keep going.
C, condylomata. These are different. They're flat, moist lesions seen in secondary syphilis. Big infectious differential. Intraepithelial neoplasia. Fin, A-N-N, pen-N. Precancerous changes, definitely need to rule these out. Sometimes needs a biopsy. M, malignancy itself, actual cancer. Always a possibility, especially if it looks unusual. And the last, C, cicatricial tags or hymenal remnants, especially in women.
Wow, okay. MSEH, HSPVCIMC. That's a useful list. Thanks. So how common are we talking here, epidemiology-wise?
Genital warts are very common, especially among young, sexually active adults like here in the UK. The HPV vaccine has made a difference, though.
Oh, yeah, the vaccine rollout. Has that significantly reduced numbers?
Yes, definitely. There's been a noticeable drop in incidence in populations that have been vaccinated, which is great news.
That is good, but still common overall.
Oh, yes. Despite the vaccine, it's still one of the most common conditions treated in GUM clinics, sexual health clinics. Estimates for developed countries are around maybe 0.15% annual incidence in adults. In the UK, the quadrivalent vaccine covering types 6 and 11 started around 2012. But yeah, clinics still treat well over 130,000 cases a year in the UK, so it's definitely still around.
130,000 a year, okay. So someone comes in, they think they might have them. What are the classic clinical features we're looking for, signs and symptoms?
The typical picture is those small raised growths we mentioned around the genitals or anus, but they can look quite varied. You might see just one or clusters of them. They can be flat or bumpy. Some people describe them as cauliflower-like in texture.
Cauliflower-like, okay. Are they usually painful?
Often they're not painful, no, but they can cause symptoms like itching, sometimes bleeding, especially if they get irritated or discomfort, and they can sometimes cause pain during sex dyspareunia. The texture and color can vary too. Key areas to check are the genitals, the perineum, that area between the genitals and anus, and the anal region itself.
And sometimes you need a closer look internally.
Yes, depending on the location or symptoms. For women, you might need a speculum exam to check the cervix or vaginal walls. For warts inside the anus, a proctoscopy might be needed to visualize them properly.
Right. So you see something that looks suspicious. How do you confirm the diagnosis? Are there specific investigations?
Honestly, the diagnosis is mainly clinical. It's based on looking at the lesions and recognizing those features we just discussed.
Just by eye, usually.
Mostly, yes. Sometimes applying acetic acid, basically vinegar solution, can make the warts turn white, which might help highlight them. But it's not very specific. Other things can turn white too, so it's not a definitive test.
Okay. What about biopsies or testing for the HPV type?
Those are usually reserved for specific situations, like if the diagnosis is really uncertain, or if the warts aren't responding to standard treatment, or importantly, if there's any suspicion of something more serious, like precancer or cancer, especially if the lesion looks atypical, or in an older patient, or someone with risk factors.
And don't forget screening for other things.
Absolutely. Given the association, screening for other STIs is pretty much standard practice when someone presents with genital warts.
Okay, so diagnosis is mostly visual, screen for other STIs. Got it. What about management? What's the plan once you've made the diagnosis?
The main aims are, first, to get rid of the visible warts. Second, to relieve any symptoms the patient is having, like itching or discomfort. And third, to try and reduce the risk of passing the virus on.
And how to get rid of them? What are the options?
There's quite a range. We've got topical treatments, creams, or solutions the patient often applies themselves at home. Common ones are pothophylotoxin and imiquimod. Then there are physical methods, usually done in clinic. Cryotherapy is common, freezing the warts off.
Freezing, right? Any others?
Yes. Surgical options like excision, just cutting them out, sometimes using electrosurgery. Laser treatment is another possibility, especially for extensive or difficult warts.
And prevention comes back in here too, right? With the vaccine.
Definitely. HPV vaccination is highly recommended, both to prevent getting it in the first place, and it might even help reduce recurrences in people who already have the virus, although the main benefit is primary prevention. And follow-up is key.
Why follow-up?
Because, as we said, recurrence is common, so you need to check that the treatment worked and watch for any new warts appearing.
Are there any special cases to think about?
Yes, a few. If warts are on the cervix, that usually needs referral to a gynecologist. Intraanal warts might need proctoscopy and specialist management. During pregnancy, some treatments, especially podophile toxin and imiquimod, are generally avoided. And if you see genital warts in a child, you must consider safeguarding issues and the possibility of sexual abuse. That needs careful assessment.
Right, crucial considerations. How well do these treatments generally work?
Things like surgery or electrosurgery tend to have high initial clearance rates. They get rid of the visible warts effectively. Topical treatments can also work well, but success rates can vary a bit more, and they often require the patient to apply them consistently for several weeks. Recurrence can happen with any method, remember, because the virus might still be there.
And side effects?
Common ones are local reactions like itching, burning, pain, sometimes skin erosion or irritation where the treatment is applied. It's important to counsel patients about what to expect.
Okay. And when should we think about sending someone to a specialist, like a GUM clinic?
Good question. Definitely refer if you're unsure about the diagnosis or if you suspect malignancy. Also for internal warts, cervical or anal. Any cases in children or during pregnancy, if the first-line treatments aren't working, and if the patient tests positive for other STIs that need specialist management like HIV or syphilis.
Makes sense. So what's the overall picture then? The prognosis for someone with genital warts?
Overall, the prognosis is generally good. The warts themselves are benign, they're treatable. The main issues are the tendency for recurrence because of that persistent virus and the psychological impact.
Psychological impact.
Yeah, having an STI can cause significant emotional distress, anxiety, sometimes stigma. That's an important part of managing it. And while the warts from 6 and 11 are low risk, we always need to keep in mind the possibility of co-infection with high-risk HPV types and the associated long-term cancer risks, although the warts themselves don't turn cancerous.
So important to manage expectations about recurrence and offer support.
Exactly. And reinforce safer sex practices and vaccination for prevention. Also worth mentioning that sometimes, if left alone, warts might actually clear up by themselves, or they could stay the same, or they could get bigger or more numerous. It's variable.
Okay. And just to be thorough, what are the main complications we should know about besides recurrence and the high-risk HPV link?
Well, the main ones are that emotional distress and stigma we mentioned. Physical discomfort or bleeding during sex is another potential issue. And as we discussed, having genital warts might slightly increase the risk of acquiring other STIs, possibly due to microabrasions or immune factors.
So regular screening and prompt treatment really are key.
Absolutely. Minimizes those complications.
Okay, I think that covers it really well. So summing up the absolute key takeaway for MSRA revision. Genital warts, common STI, caused by low-risk HPV 6 and 11. Treatable, yes, but recurrence is frequent because the virus can hang around. They're benign, but always consider potential co-infection with high-risk HPV types.
Spot on. And don't forget the differentials, MSE, HSPV, CIMC. Knowing what else it could be is crucial. Hopefully going through it like this helps lodge it in your memory.
Definitely. And listeners, for loads more high-yield revision resources to smash your MSRA, do check out passthemsra.com and also freemsra.com.
Yeah, great resources. And maybe a final thought, understanding a condition like genital warts, even though it seems quite specific, it really forces you to think about the virus, the patient's immune system, the psychological impact, public health measures like vaccination. It connects to so many areas of medicine.
That's a great point, seeing the bigger picture, even in common conditions. Thanks so much. That was incredibly helpful.
My pleasure. Good luck with the revision, everyone.